Hi, everyone. Welcome to Human Answers to Your Non-Hodgkin Lymphoma Questions, Understanding the Latest in Treatment Options. I'm Tiffany Drummond, a patient advocate with over 20 years of experience in cancer research. My journey as a care partner began when my mother was diagnosed with endometrial cancer in 2014. I quickly realized the challenges of finding resources, support, and shared experiences. And now I am committed to helping others avoid those similar difficulties no matter the condition. That's why we at The Patient Story create programs like today's to help you figure out what comes next. Think of us as your go to guide for navigating not only the cancer journey, but your overall health journey. From diagnosis to treatment, we've got you covered with real life patient stories and educational programming with subject matter experts. I genuinely am your personal cheerleader. I am here to help you and your loved ones best communicate with your healthcare team as you go from diagnosis through treatment and survivorship. Before we get to our speakers, we want to thank our sponsors, GenMab and AbbVie, for its support, which helps us to host more of these programs for free to our audience. The Patient Story retains full editorial control over all content, as always. I must also thank all of our promotional partners for their support. It is truly because of you our programming reaches an audience who needs it. So I hope you find today's program helpful, but please keep in mind that information provided in this program is not a substitute for medical advice. Finally, we know there's a lot you want to know more about and discuss, or at least tune into. Please let us know what those are, along with what we could do better. A survey will pop up after this program ends, so make sure you don't go anywhere. I have the pleasure of interviewing Dr. Peter Martin, and it just so happens that we have a lot more in common than you might think. I will also be speaking with a follicular lymphoma patient, Lori. I think it is so important to get a real patient perspective, and I am sure her experience will resonate with you and or your loved ones. Let's learn about Lori's journey before deep diving into the latest treatment options.
So I was diagnosed in 2006. My son was in kindergarten. There was one treatment, which I did right away. We thought I was in remission, so I went merrily back to work, traveling internationally. But just 3 months later, my cancer was back on the first follow-up scan. So that started 12 years of treatment. So from 2006 to 2018, I was in continuous treatment and underwent 7 different lines of therapy, including 3 clinical trials. And the first 6 didn't work, unfortunately, but thankfully the 7th line of treatment did work. I live in Los Angeles, so I had access to great cancer centers. So I went to 4 different big cancer centers in LA. And that's where I was able to get trials. So I was really lucky to live in LA because I had access to all these different facilities and access to all these specialists and new trials. So in that sense, I was real lucky with where I was.
Hello, everyone. Thank you to the Patient Story audience. My name is Tiffany. I'm sure you've seen me before. I am the manager of programming here at the Patient Story. Today, we have a special guest. We are going to be talking about understanding follicular lymphoma, right? That non-Hodgkin lymphoma, that subtype. And so today I have an excellent expert with me. I have Dr. Peter Martin. Dr. Martin, how are you doing today?
It's great to see you again, Tiffany. I don't know if everybody else knows this, but we worked together about 15,
We did.
10, I won't say how long ago.
You can say it. You can say it about 15 years ago. Me and Dr. Martin, I used to call him Peter back then. So that's how far we've come. But I am glad to see that we both have stayed the course, which is fighting cancer and finding a cure for that. And I know that you did amazing and done great strides in that. So I do thank you for being here. So let me tell the audience a little bit about who you are. So Dr. Peter Martin serves as the professor of medicine and chief of the lymphoma program at Weill Cornell Medicine. He is a hematologist oncologist who specializes in caring for patients with lymphoma at New York Presbyterian Hospital. And his research focus, which, if you know, is very dear to my heart, is on clinical investigation of new and promising therapies. So that was a mouthful, but you are somehow able to do it all. So again, thank you so much for being here. And I'm pretty sure our audience, who are very engaged, is going to get a lot out of this conversation. So are you ready to get started?
Let's do it.
Now, someone like me, I am a patient advocate for many types of cancer, but for those of us who aren't as familiar, can you kind of break down follicular lymphoma? And we know that it's considered an indolent lymphoma. So can you kind of walk us through that characteristic and what makes follicular itself distinct from those more common types of non-Hodgkin lymphoma, such as DLBCL or diffuse large B-cell lymphoma?
Yeah, follicular lymphoma is actually pretty common from the lymphoma perspective, but not common from a cancer perspective. It's probably about 20,000 people every year in the United States are diagnosed with follicular lymphoma. There are probably now, depending on your perspective, up to 130 different kinds of lymphoma, which is a lot. Hard to keep track of all of them. And each subtype is a little bit different biologically. That's how they're defined. And they all can behave a little bit differently clinically. Follicular lymphoma is really based on the way it looks under the microscope. And so that's where the name comes from. It looks like it's little follicles in the lymph node. But the way it behaves, you're right, is an indolent lymphoma, which means that it, in general, typically grows slowly over months, years, or decades. And that's why we call it indolent, which means lazy. I like that word lazy because it's a lymphoma that can't be bothered to cause problems, right? So when it's diagnosed, we'll often talk about the goal of treatment, and that's really to try to help somebody live a life that's as close to the life they would live without lymphoma. So it's one that kind of hangs around for a long time, and we just keep managing it and kicking the can down the road.
Well, this brings me to an interesting question I'm actually interested in. I didn't know it was considered lazy, but I love that. I love that name for it. So if someone is living with this for years or even decades, how is it diagnosed? Do they come in for some other type of symptom that usually makes them get referred to a specialist? Or how does that work for a patient who doesn't even know that they have it?
Can vary a little bit. I mean, ultimately, in order to diagnose follicular lymphoma, you have to look at it under the microscope. That word lymphoma literally means tumors of the lymph nodes. So most of the time that we meet somebody with follicular lymphoma, they'll have an enlarged lymph node. That might be something that they notice very often. Typically, it's a painless enlarged lymph node that they might feel in their neck or armpit or groin. It might be something that was picked up accidentally while they were getting testing for some other reason. That's pretty common because it's something that often is totally asymptomatic. Sometimes, although it's called lymphoma, it's not actually in a lymph node. It might be present in the bone marrow or some other organ like the gastrointestinal tract or the skin. Ultimately, though, somebody has to look at it under the microscope, and that's how we make the diagnosis.
Lori, did you experience any symptoms prior to your diagnosis, or was it more so something, maybe you noticed it but didn't read into it enough to get it checked out right away? What was that experience like for you?
When my son was 3 years old, I started to get frequent sinus infections and just couldn't get rid of them. I also developed a dry eye. I was a longtime contact lens wearer, and I suddenly couldn't wear my right contact lens. And I was very tired. I had a lymph node on my neck that was concerning me. And I felt something in my abdomen. And my doctors all roundly dismissed me. I think it was a function of being female and also blonde. Didn't help. I would specifically ask them, I'm very worried I have lymphoma. And they would say, well, look, your blood work is all normal, so you don't have cancer. And I even took my husband with me to these appointments and he couldn't believe how I was dismissed. And he was mortified. He could not, because I told him they won't listen to me, and he didn't believe me. So this went on for a good 3 years. And I wanted to believe these doctors. I wanted to believe that it was just allergies that, were causing these sinus infections. And also, too, I was dismissed because I was considered in the age where I could be starting to get perimenopausal symptoms. So my hormones. Yeah, a lot of people get dry eye because of their hormones. And, it was the most aggravating thing. But I just kept feeling worse and worse and worse. And then the exhaustion was really incredible. And one of these doctors I saw, he said, Lori, he said, I'm listening to you, and you're president of a software company. You're traveling internationally a week, you're traveling a week a month. You're running a household. You have a young boy that you're managing him, because no matter what happens, the mom always does so much. My husband had his own business, so he had his own challenges. And he said, I'm just exhausted listening to you. So I finally got to someone I knew who might know a diagnostician. And she referred me over to this diagnostician who took me seriously at last. And so I went in to see him. I explained everything. I said, people think this node is just from allergies. And he said, well, did you get tested for allergies? And I said, yeah, and there was nothing. So he said, okay, well, that doesn't make sense then. And I explained about the hernia. And he said, yeah, it feels like it could be a hernia. But he said, Lori, we don't guess. We have CT machines. And I'm going to send you to a hernia specialist. We're going to image you. And that week, they imaged me. And it was really scary because I was supposed to go in for a simple image. They expected to find a hernia, and I wasn't supposed to have contrast. And suddenly this lady's bringing in the bottles of white gunk. And then they said, they had to run an IV line because they had to do a better image. So my heart just began to sink as I was sitting there. And just 2 days later, on Good Friday, the Good Friday of 2006, the doctor's office called and said I needed to go in that day. And they didn't tell me to bring anyone with me. I just went in by myself. And they told me I had some sort of either lymphoma or a mesenchymal tumor. They had also, the imaging had also detected lesions on my lungs. So he said, you may also have lung cancer. And that's when I found out, and that I had some sort of cancer. So I spent the long Easter weekend. My mother was in town. My brother had flown out from Boston with my mom, who had dementia, but they had come out for the Easter weekend. And I find this out all on Easter weekend. And I'm, of course, looking online. I knew a little bit about lymphoma just because when I had this node, like when I put in my symptoms, it kept coming up lymphoma. But 90% of lymphoma patients are diagnosed at stage 4 because most patients don't have symptoms. Now, I did, but I didn't have anybody listening to me. So they just dismissed my concerns. And as it turned out, it was actually really good that they didn't listen to me, because the only treatment that existed at the time, this monoclonal antibody multi-chemo prednisone treatment, if I had had it 2 or 2.5 years earlier, it wouldn't have worked, and I would have had nothing else. I mean, as it was, I had an auto stem cell as an option, but it was not a good option, especially if you relapse after that first line of chemo and monoclonal antibody treatment. So in a way, I had to say, it ended up kind of being a blessing, because by the time then they were pushing me to do the auto transplant, I managed to find a trial of an HDAC inhibitor, which is what I did as my second line of therapy.
Yeah, oftentimes it's even like somebody will say, I've had this lump here for like 5 years. And finally, my friend said, you should really look into that, but that's a testament to how it behaves. It just kind of hangs around for a long time. So people are often just get accustomed to it being there before they decide to bring it to somebody's attention.
Absolutely right. So that's where caregiving comes in as well. I'm a caregiver as well. So now let's kind of talk about treatment, right? This is where our patients and our caregivers get really engaged in this conversation. So before we get into the more new novel approaches, can you kind of walk me through what the traditional treatments are for follicular lymphoma and what those factors are that determine a more or less aggressive approach in your practice?
I think the job of a hematologist oncologist is to sort of learn as much as we can about the lymphoma. And that's changing all the time as we get more sophisticated. To recognize that this lymphoma doesn't happen in a petri dish in a lab somewhere. It's happening in a real live person. So we have to learn as much as we can about that person. And that includes not only their medical issues, right, which vary from person to person, but also all of the things that are important to that person. What are their values? What is their support network like? There are 8 billion of us on the planet, and we're all different. So there's even more heterogeneity among people than there is amongst the 130 different lymphomas, right? So then we put all of that information and we come up with a plan that makes the most sense for that person. And you're right that treatments are constantly evolving, and we have new treatments available today that we didn't have in the past. In general, though, the goal of the treatment, as I mentioned, is to try to give somebody the life that's the closest to the life that they would have if they didn't have lymphoma. And so those approaches can vary. In some cases, it's like you say, well, look, this is not causing you any problems. It's not going to cause problems, hopefully, for a long time, on average, multiple years. And so we just watch it, and it sits there. And that can be a little bit counterintuitive. I think in the Western world, you want to catch cancers early and deal with them early. That's certainly the case for breast cancer, lung cancer, colon cancer. So it's a little bit awkward sometimes, that initial discussion around follicular lymphoma. You say, oh, great, no problem. Let's do nothing about it, But it's proven. It's a proven strategy to help people live a good quality of life without having to deal with any of the side effects of treatment. Sometimes on the other end of the extreme, we might propose using more aggressive therapies, including even chemotherapy, if we need to shrink something quickly and help them to feel better. And then there are options in the middle where we use just kind of immunotherapies that may shrink the tumor, may help somebody to feel better, and may prolong the time between that and other kinds of therapies by months or years. So there's pretty vast options there, and more new treatments that are being approved are moving into that space that give us even more options.
Absolutely. So, one thing I do remember about you back in the day is that you were always in the lab. So let's kind of talk about some of this data that came out of ASH, specifically when it comes to bispecific antibodies, which is a new, I don't want to say buzzword because it really is changing the way that we look at and treat cancer. And so especially when it comes to immunotherapy. And so can you really talk to us and the audience about bispecifics, specifically what benefit it may contribute to our relapse refractory follicular lymphoma patients?
Bispecific antibodies are a type of monoclonal antibodies. Antibodies are proteins that our own immune system makes to fight against bacteria. A few decades ago, clever people figured out how to make antibodies that would fight not against infections, but against cancer. That was moved quickly from the lab into people. And for the past 25 years, that has really revolutionized the way that many cancers are managed, but started with lymphoma. We've been leading the way for a long time. Bispecific antibodies are sort of a natural evolution of trying to come up with ways to make this kind of immunotherapy work better. And they're very cleverly engineered in a way that these antibodies bind to tumor cells the same way an antibody would bind to a virus or a bacteria. But in addition to that, they also bind to other parts of our immune system called T cells, and they activate those T cells. When those T cells are activated, they secrete a bunch of chemicals called granzymes and perforins that literally poke holes in the cancer cells and cause them to die. So this is a really clever way of using our own immune system that's sitting there right next to the tumor cells and causing that immune system to kill the cancer cells. And it does it remarkably effectively. The vast majority of people will have not only responses to this treatment, meaning the tumor shrinks, but in many, if not most cases, the tumor will totally disappear on a CAT scan. Doesn't mean that it's totally gone, although it might be totally gone. We'll find that out as the years go by. But it totally disappears on a CAT scan in a lot of people. So it's attractive in that it's a kind of non-chemotherapy approach. It's attractive in that it's a proven form of immunotherapy. It's an evolution of the kinds of immunotherapies that we've been using in the past. And it's just more effective than the immunotherapies we've had in the past. The other thing that's nice about it is that it's off the shelf. So it's, you order it from a pharmacy, it comes, you administer it, and there you have to go. It doesn't have to be engineered specifically for each patient the way something called chimeric antigen receptor T cells or CAR T cells have to be.
Lori, I believe you are familiar with CAR T therapy. How was that experience, and where are you currently in your cancer journey? And also, are you familiar with bispecifics? Me and Dr. Martin have been talking about that. And if so, I would love to get your perspective on this immunotherapy versus CAR T as a patient from that perspective.
So it was really interesting because I actually heard about CAR T 6 years before I could get it. I heard about it in 2012 when I attended an LLS event where they showed Emily Whitehead's film. And I went into my oncologist that week because I was on a study visit. And I said, how come I don't know about this? He said, because they're not trying it for follicular. They're doing it for these, more aggressive tumors. Now, my tumors were plenty aggressive, plenty of times. But he said, we just have to wait. You're on this PI3 kinase inhibitor. We're going to ride this horse. And that took me through 2016 when the cancer finally outsmarted that pill. And then there was a new monoclonal antibody that had been approved. That was a 9-month course. So I did a monthly infusion of a third-line monoclonal antibody, obinutuzumab. Who comes up with these 18-syllable names? I don't know. So I immediately started shrinking my tumors again. But as soon as I stopped that infusion, it came back. And so it was a race against time. So in 2018, my tumors were huge, huge. And in 2000, it was like April of 2018, I was out hiking. My oncologist called me and said, we finally got the trial for follicular. It's going to open at UCLA. We're going to have 5 patients enrolled in the first cohort, and you will be patient number 1. So then I went in and I had to do, when you're in a trial, you have to go review the paperwork. You sign the study paperwork. It discloses all the side effects other patients who were in the phase 1 study had. And this was a phase 2 study by this point. So it wasn't completely bleeding edge. And then they have to do biopsies. They have to do imaging. They have to do MRIs. They had to make sure I didn't have anything in my brain because at that point, they weren't allowing patients with central nervous system to get CAR T because they didn't know yet how it would work and what it would do. Now they know it's amazing. So they do it for people with involvement in the central nervous system. And then I had a sinus infection again because my cancer was coming back. So of course, just like when I was first diagnosed, and my oncologist said, you can't go into CAR T with an active infection. So I went to my ear, nose, and throat specialist. By this point, I had a good one. And I explained to him, I need to get this treatment, but I can't do it. He called in his scheduler, said, I want you to clear the schedule tomorrow. Those are not urgent. I have an urgent patient, and they operate on me the next day. Ended up being a major surgery with general anesthesia because there was so much blockage everywhere. So he got me cleaned out. We got rid of the sinus infection so that I was good to go. Then they do about a month before you get your cells back, they do apheresis. So they harvest your T cells. Very easy process, half a day outpatient. Then they take the bag, the courier leaves with your bag to ship it to the CAR T company, who happened to be just down the highway in LA because I was getting Kite and they were just in El Segundo. So I remember the courier came to pick it up in the apheresis center and I said, do not let my cells fall out on the freeway. Please make sure the van door is tightly sealed. He said, don't worry, we'll get it there, Lori, no problem. And then it's about an 18-day process. Actually, when I saw Kite yesterday, they've shaved off 2 or 3 days. And they're shortening it even more. So the patient doesn't have to wait that long. But they take the cells and they put the target on it and then they grow the cells in the lab. So they harvested about 1 million cells from me. And after they became CAR T cells, they were now 1 billion cells that were going to get infused into me. And then just before you get your CAR T cells, you go through lymphodepleting chemotherapy, which is really chemo light and compared to the 18 chemo cycles I had. What it does is it makes room in your bloodstream for you to get your CAR T cells back and to give them room to expand. So that's why they do this 3 days of lymphodepleting. And then on your day 0, your CAR T birthday, you get the cells back. It was amazing because within days, the tumors were shrinking.
Are there bispecific antibodies right now that are available to patients outside of a clinical trial? Is there anything that we can use now that we can get straight from a pharmacy without having to go to our investigational one?
There are two currently two bispecific antibodies approved for follicular lymphoma. One is called mosunetuzumab. The other one is called epcoritamab. There probably will be a third one in the very near future called odronextamab. They're all pretty similar in terms of the way they work, how they work, the proteins that they target on the surface of the B cells. And there are more coming. We will continue to see this not just in lymphoma, but across all cancers. They're all administered in the clinic or in the hospital. So these are not pills that you take at home. The way a lot of cancer therapy has transitioned, they're all administered either in the clinic or in the hospital, either through an intravenous injection or a subcutaneous injection.
Is there a reason for that? Is it because we want to watch for any type of side effects immediately, or is it just because of the toxicity and potency of the drug itself?
Yeah, good question. A little bit of both. They do. So in terms of just practicality, these are big proteins. They have to be administered by a needle. It has to bypass the gastrointestinal tract. So it has to be administered by a needle. You're right, there are some side effects. Relatively speaking, the kinds of side effects that somebody might experience during the infusion itself is pretty minimal. That said, somewhere in a range of hours to even a couple of days after the infusion or treatment, there can be something called cytokine release syndrome. And this happens probably in up to about a third of patients getting these antibodies. Typically, what that is, it's a complicated name, cytokine release syndrome, but it's what I described. It's basically these T cells are secreting these chemicals, and those chemicals are the same chemicals that you experience when you have a fever or an infection, pardon me, including things like fever, feeling kind of lousy, run down, muscle aches, all the stuff you have when you have the flu. That's what it is. But in some cases, it can be a little bit more severe than that. Not very common, but it can happen. So we're often able to manage it just with Tylenol. Sometimes we have to use steroids like dexamethasone, and rarely there are even other medications that we have to use. So because of that, there's very careful preparation at the facility level, at the physician nursing level, at the patient and caregiver level. It's all about preparation, helping people to know what to recognize and then what to do if something like that happens. It's very manageable, but it's a little bit more complicated than just a pill.
Right. So this brings me to a question about safety. A lot of patients are concerned about side effects in general. And we know when it comes to cancer, a lot of these drugs are just kind of toxic in nature, even though I can say that just over the decades, how we've drastically reduced that. But how do these bispecifics, in your experience and your determination, differ than like traditional chemotherapy and other like CAR T cell therapy in terms of the side effects? Are they more severe, less severe, or not as long? And does that really impact quality of life and one's determination on which avenue they want to take for their treatment?
Yeah, good question.
Loaded question. I know. That's what I do, Dr. Martin. You haven't seen me in a long time. I ask loaded questions now.
So it's not such a straightforward question to answer because everybody's different and everybody's situation is different, right? And so where better tolerated treatments might be appropriate for one person, more aggressive or treatments with more side effects might be really appropriate for another person. In some cases, or in most cases, we have options to choose between all of these, and oftentimes there are not really wrong or right answers. We just have these options and we try to pick one. But in some cases, we're really driven to say, okay, no, this is the right answer. And so it's the job of the whole team, the patient, the caregiver, the physician, to try to pick that right treatment. Bispecific antibodies, I think, they're straightforward in that they can be often administered in an outpatient setting, or at least partly in an outpatient setting. They don't cause a lot of the side effects of traditional chemotherapy, like hair loss, nausea, that kind of stuff that, frankly, are not major issues with a lot of chemotherapy we use, but I think we're understandably scared of them. And particularly hair loss is kind of an interesting one, and that, it's just hair, but it's this sort of taboo signal to the rest of the world, something that you're undergoing privately, and it tells them publicly that something's going on. So I understand why that's not attractive.
I think it's important to get a patient's perspective also regarding side effects. Lori, can you give us an overview of your experience with side effects? Were there any that you found particularly taxing on you or that affected your quality of life? Or were you able to manage your symptoms relatively well? What was that like for you?
It was a mixed bag, definitely a mixed bag. Like the first chemo, I lost my hair. I got mouth sores. The second treatment, which was this targeted treatment, I was very, very fatigued. I also lost hair. They told me, oh no, it's not from the trial drug. And then I dug down into the trial and I saw a very small percentage of patients lost their hair. And, but yeah, that's kind of a standard response from the doctor and the investigator. Oh no, that's not our drug. So this, let's say, third and fourth treatments. Fourth treatment was radioimmunotherapy. I had very, very low counts for a long time. My platelets dropped. I never had to get an infusion of platelets, but I had to go in every day and get it checked. I had to be very careful not to fall. Because I had no clotting ability with low platelets. White counts typically would get depleted, which made me prone to getting infection. So I had to be careful. I remember when I went back to work after my first chemo treatment and I had to start traveling again, I said to my oncologist, this was in end of 2006, I said, is it okay if I travel to New York and Boston and London, et cetera? She said, yes, Lori, but you have to wear a mask. So I was a real early adapter wearing a mask.
Thank you, Lori and Dr. Martin, for talking about the side effects, because this really is a conversation that our patients want to hear about, especially from our doctors and patients that we have here on the patient story. Now, something that was also talked about at ASH, Dr. Martin, in general, this idea of precision medicine and how it's a relatively new approach to cancer treatment, but is precision medicine being used as an approach to follicular lymphoma? So, what is your take on that? And I know it's another loaded question, Dr. Martin, but I hope you're having a great day with me right now. So let me know what your thoughts are on precision medicine.
Yeah, it depends how much of a fan of science fiction you are. I mean, to some degree, we've always practiced precision medicine in terms of saying, okay, what do I know about this lymphoma? What do I know about this person? What do I know about all of the different treatment options? And how do I put it all together? Right? The things that change over time are treatments become more specific in some ways, so you can apply them under certain circumstances. Our ability to understand more about cancer changes over time with new technologies. So we've always been trying to sort of personalize medicine, but in the sense of sequencing the entire genome of a cancer cell and saying, okay, this is the exact right treatment for you according to my lab testing. We're not there yet in follicular lymphoma. Unfortunately, we're not there yet. There's one treatment where we sort of are. There's a pill called tazemetostat, which has modest activity, but it's generally pretty well tolerated. It's an inhibitor of an enzyme called EZH2, which is mutated in about 20% of people with follicular lymphoma. So it's approved for treatment of people with mutated EZH2 enzyme. Not, yeah. So But it's also approved for people with wild type, unmutated EZH2 if they don't have other treatment options. And realistically, it works reasonably well in both groups. So it's a precision medicine approach, but frankly, you don't necessarily have to have the mutation in order to use it. That's the closest we have right now. But this is coming. It will continue to change, and there are other examples where we'll see more of that.
Yes. And so I know you can't read the future, but I don't know. You give me that you can. So, what do you think the long term implications may be for follicular lymphoma, specifically for these chemo free treatments? Do you think in the long term this is going to be something that um, prolongs? I mean, I think what I hear a lot, which I love hearing, is that I'm living with, not that I have this cancer, like I'm living with this cancer. And so, what do you see with that in terms of chemo free treatments, the long term implications of that?
Yeah, a few things. One, I think people with lymphoma want treatments that work and that are well tolerated. And whether you call them chemotherapy or immunotherapy or whatever, if it works real well and it's well tolerated, that's already great, right? I think they also want options that sort of conform to where they are in life. And so every year we have more and more options available to us, and we always try to pick the right treatment for that moment. Thinking about the here and now today, what are we going to get today? We also try to think about, well, you're 60 years old, right? You're supposed to be alive for another 20, 30 years. How does what I do today impact what your life is going to be like 10, 20 years from now? So I think these new treatments, maybe more than chemotherapy, have the potential to have a lesser impact on the body in that longer term setting, 20, 30 years from now, whereas multiple lines of chemotherapy back to back to back to back, people will get through it. We've been getting through it for decades already, right? Without major issues. But over time, it kind of catches up. And so having different treatments that work in different ways, I think has the advantage of potentially allowing us to sort of mitigate some of the short term, but also some of the really long term issues that can sometimes come up. All of these treatments are having more options is always better.
I agree with that for sure. And so I know that both of our backgrounds are really heavy into research. I'm more compliance, whether that's a good thing or bad thing for my researchers out there. I think they love me, but I always call myself the no girl. But in terms of clinical research, how receptive are your patients to that? And I like to talk about clinical research anytime I do a program, just to get the point out there, because oftentimes some people think that clinical trial is one of their last resort, or that they're not at least getting a standard treatment, or they're not getting treated at all for their cancer. And so I know that at Weill Cornell, that, when I was there, at least, it's a really robust research program that you have. And kind of just talk about, you can even talk about it, and, specifically at Cornell, what your research program looks like and how receptive your patients are to joining clinical trials.
Yeah, I appreciate your disclosure there that we're both coming from a research background. And so people should take that into account, knowing that we have those biases. The number one barrier to entrance into clinical trials is not patient refusal. It's not knowing that there's the opportunity, right? So the real burden is having physicians let patients know that this is something that they could do, not patients saying that that's something that they don't want to do. So number one, it's us. We're probably the bigger part of the problem. And there are different reasons why somebody might want to participate or not want to participate in clinical trials. It offers new opportunities to have access to new treatments that might be more effective or might be better tolerated. And in some cases, that might be, yes, when other treatments have been exhausted. But in a lot of cases, it might be when this new opportunity has already been really well studied in another setting. And so you're looking to apply it in this new setting, knowing that it worked so well in line 3. Maybe then try it in line 2 because you think it's going to work even better, right? So there are also some downsides to research. a little bit more of a hassle often.
However, I am a proponent of decentralization. So a lot of patients now are able to get labs locally without having to track things like that. But yes, I am a little biased when it comes to clinical research, but I do think it has so many benefits. So I'm always out there promoting it.
Yeah, can't be understated that historically there have been a lot of questionable research practices, we'll put it that way, that were not always in the interest of participants. And I think that, the medical community on the whole has sort of tried to grapple with this. And, we've got multiple committees now, hospital committees, patient advisory committees that try to minimize that and try to make research as ethical as possible. But there are going to be some people who are distrustful of it, and that's their prerogative. I'm never the person who's going to, twist somebody's arm to participate in a study that they're not comfortable with. But I'm also not going to shy away from proposing a study because I'm afraid that somebody is, just not going to go for it. I think that's not a respect to their autonomy either. You propose every option that exists and talk about the pros and cons, and people will decide what's right for them.
Absolutely. I always say too that I think we don't give patients enough credit, right? When we always talk about patient education, like they're educated, they just need to know that it's out there, and they'll be, more than willing to make that informed decision for themselves. So thank you for giving me that discussion. I always love talking about clinical research, as you know. Now, going back to ASH a little bit, right? As before we wrap up, this is something that I think is less talked about in general when it comes to cancer, and that is fertility. So I know at ASH there was one abstract that I saw that was talking about fertility, and I guess this will, kind of go into our more younger patients with follicular lymphoma. And so how do you even, does that discussion come up? Because what I saw from the abstract is that a lot of patients don't bring it up, like they don't really want to discuss it. And what has your experience been with that in terms of having a fertility discussion with your follicular patients?
Yeah, fertility is also a highly charged issue, but it's like research. It's something that if you don't talk about it, people don't have the opportunity to consider it. So it's really, from my perspective, important from the physician perspective to ask people about where they are, where they're thinking about that. But it's definitely also something that patients should advocate for themselves if it's something they're thinking about. In general, follicular lymphoma happens as we get older, but there are a significant number of people, probably 20% of follicular lymphomas happen in younger people. And some of those are considering having children in the future. We'll get away from sort of some of the social reasons why somebody might choose to have children or not have children in the setting of cancer. That's a whole other complicated discussion. But many big hospitals, including Cornell, New York Presbyterian, we have fertility teams that help people to consider all of their possible options and how to preserve fertility. I will say, fortunately, even the chemotherapy regimens that we typically use in follicular lymphoma don't have major impact on fertility. And a lot of the newer treatments really have what we think is no impact on fertility. Caveats being that you don't necessarily want to be treating the lymphoma at the same time that somebody's pregnant. Although, in many cases that becomes necessary, and it turns out that that's depending on the treatments we use, often not a problem either. But definitely needs to be a discussion, and it needs to be a discussion early so that we can think about all of the treatment implications, not just now, but also sort of longer term and how we sequence things.
Thank you for saying that. And I can just say to my patients out there and caregivers and loved ones out there and partners, that is a conversation that you want to have if you are considering children, or maybe not, like, if you're, one of those not rare, but you're younger and you're considering children, advocate, right? I'm a patient advocate. So you need to advocate for yourself. And if your physician doesn't bring it up, don't be afraid to bring it up because they didn't. Which brings me to another point that I didn't put didn't ask you beforehand and let you know that I was going to ask you, but I want to talk about community doctors, right? I see that, just in my experience talking to patients, they really don't get their diagnosis till after they probably see their primary care, or again, they went to the emergency room for something totally different. And because you are a large research center and you do have multidisciplinary teams like fertility and nutrition and things like that, which many people don't have, maybe they're just going to their one community clinic that they have. Do you work with any community clinicians or community hospitals in terms of outreach for patients who may not really know to go to an academic research center because they're not there yet, because they haven't been referred to a specialist? What are your thoughts on, working with community doctors to bridge the gap?
Yeah, a few things. One, you're right that even in New York, where we have multiple academic medical centers, the majority of people with cancer are managed outside of those academic medical centers. So that's just a reality that we have to acknowledge. Number two, I recognized this a while ago, and so I also work in Brooklyn a couple days a month. Um, yeah, anyways, we'll talk about that some other time. I think it's important that people have access to medical care in their community, and that it's probably not. It took me a few years to come to this conclusion, which is embarrassingly slow. But it's probably not fair to expect people and their caregivers to travel a couple of hours to see somebody when they do have access to medical care in their community. I think what we have to do is bring better medical care to the communities that people live in rather than vice versa. Um, yeah, there are lots of excellent oncologists practicing in communities, um, and that's where the majority of the people can and probably should receive their care. The one caveat I'll say to that is that cancer is becoming increasingly complicated. All of cancer, and so I don't think that people should feel uncomfortable reaching out for a second opinion. Um, I very commonly work with. I have friends who work in community medicine throughout the whole tri-state area in New York, and I work with them and help them to manage their patients. Telemedicine has made that easier as well, to say, look, this is where I think you stand. This is what you could do close to home. This is what you could travel into Manhattan for if that's what you want to do. But yeah, I think this is where patient advocacy comes in. You have to advocate for yourself and speak up about it. And if your physician um, is uncomfortable with that, that might be a sign that they're thinking about more than just your own best interests. You'll find that almost all academic oncologists will encourage second opinions, and I certainly do that and help to arrange them when I can. So
You never know. I might refer someone to you, Dr. Martin. I'm having such a great conversation with you. This is amazing. So I kind of will end it here with you. Again, I don't want to keep bringing up ASH, but I know it's such a big conference. Was there anything for you personally that you were like, you know what, wow, this is like really interesting, and I want to that stood out? If not, it's okay. No offense, Ash, we love you. But if there is anything that stood out to you, feel free to talk about it.
yeah, two things. One, the bispecific antibodies are clearly going to be a major part of treatment for follicular lymphoma. Exactly how they fit in, which line of therapy and which combinations get used, I think is really interesting to think about. But they're not going anywhere for a while, so that's pretty cool. The other interesting study that came out was a late breaking abstract looking at an antibody tafasitamab combined with lenalidomide and rituximab. This was a randomized controlled trial, so it's a big international trial that showed that the addition of this drug tafasitamab to lenalidomide and rituximab improved time to progression. Effectively, it doubled it compared to lenalidomide and rituximab, which is probably one of the more common second or third line treatments for follicular lymphoma. So that's a pretty significant benefit. Um, and in some ways, it's a no-brainer to say, yeah, that's something we should do. On the other hand, tafasitamab is a little bit of a hassle. People have to come into the clinic pretty frequently for it. And so I think it'll be, interesting to see where this plays out. everywhere, including, I don't necessarily know how I'm going to use that information. Again, it comes down to a balance. What do you get out of it, and what do you have to give in order to get that benefit, and is it worth it? But it's a strikingly positive trial.
Perfect. Thank you so much. Now I'm going to be following that trial as well. So I want to, again, thank you so much for this engaging and insightful conversation. I always learn something on the other end of these educational programs. And so, again, Dr. Martin, I just want to thank you for taking the time to speak with us here at the Patient Story. And I'm pretty sure we'll get a lot of feedback. I encourage everyone to please ask questions because I have a direct line to Dr. Martin. So if I need to, I can follow up with him to ask him any questions. So thank you and have a great evening.
Thanks, Tiffany.
I cannot thank Dr. Martin enough. It was so good to not only catch up with my old colleague, but to know that we both have remained dedicated to improving cancer care and finding a cure. I am totally optimistic about the future as long as we have physicians and researchers around like Dr. Martin. I also want to thank Lori for sharing her story with us. Lived experiences are very personal, and I am forever grateful to all of our patients who are open and transparent because I really believe that it helps the next person and the next patient. To wrap up this discussion, I want to leave you with the takeaway that it is so important to be empowered so that you and your caregivers can make informed decisions about your care. That includes being educated about the latest treatment options for your cancer. A reminder, we want to hear from you. A survey will pop up when this program closes, so do not move. Thanks again to our sponsors, Genmab and Abby, for its support of our independent patient program and to our promotional partners. Until next time, I'm Tiffany Drummond signing off, and on behalf of the Patient Story, thank you for watching.